Welcome to Valley View University. I would like to thank everyone for joining today. Just a couple of comments before we get started. Any questions you have, you can submit in the question and answer format at the bottom of your screen. Your questions could be answered in the presentation, the Q&A chat, or live at the end of the presentation. And if you're going to put a question in the Q&A area, please don't put any personal health information in there. We will not be able to answer those questions. So thank you again for joining. I'm Dr. Scott Castle, and we'll go ahead and get started. Okay, today we're going to give a talk on robotics and urologic surgery. And I want to talk to you about what are some up-to-date options that we offer patients for robotic surgery in urology. I'm Dr. Scott Castle. I'm part of Rocky Mountain Urology. Our talk today, I want to show you our whole department and who all is in Rocky Mountain Urology. And I want to talk about what surgeries we do, specifically those robotically here in Rocky Mountain Urology, and then also talk about Da Vinci robotic surgery, which is the main focus of our talk. This is our providers in Rocky Mountain Urology. There's myself on the left. We have very skilled and diverse staff. We take care of every urologic condition, and this is from start to finish. We do men's health, women's health. We take care of everything from kidney stones and large prostate, and then also cancers of the urologic organs. So we have Ashley Gilly, who's one of our nurse practitioners here. She's been practicing for quite some time. My other partner, Dr. Cabra, Dr. Lowe, and Dr. Williams. We have an excellent team here at Rocky Mountain Urology and are happy to see any patients in the future. A little bit about myself. I grew up in Tennessee. I went to the University of Tennessee. I originally got a degree in biomedical engineering. I actually did work for a medical device company for a very brief time, decided that was not my trajectory in life. After I went through med school, I actually did all my training at the University of Miami in Miami, Florida. We had a high level of all range of things from trauma, transplant team, large volume of cancers of urology. I graduated there in 2016. So all the things we're talking about today, I did several hundred of these robotic operations in training, and then have done a fairly high volume ever since I graduated from there in 2016. Prior to moving to Colorado, I was an assistant professor of surgery at the University of South Carolina. I moved to Colorado about 2 years ago, and we've been working strong to get our robotic surgery program up and running here at Valley View over that time. So we've been gradually increasing our volumes over the past 2 years. So what surgeries do urologists perform? What you see here is kind of a diagram of the urinary organs. So I like to think of urologists, we're kind of like the, plumbers, just a highly sophisticated one for the entire urinary system. So these might include operations of the kidneys. The kidneys are the organs in your body that make urine. That urine is then dumped into these funnel system, and then these drainage tube called the ureters, which go down to the bladder. Your bladder is the organ which stores your urine, and then your body's going to eliminate that out of the body. For men specifically, it's got to go through the prostate and then out through the urethra to the end of the penis. So urologists, we are the complete men's health person for every male issue. And then we do a significant portion of women's health with regards to urinary health and also vaginal health and pelvic organ health. In general, these are some common conditions that we treat in urology. So we're the main person who treats any cancer involving urinary organs. Those would be the prostate, bladder, kidney, ureter, which are those drainage tubes of the kidneys, and any testicle cancer or penile cancer. We're the primary person that you see, and you're if you get one of those, a lot of times you're stuck with us for the majority of your life. We also very commonly do with enlarged prostate, erectile dysfunction. Those are probably most common of the visits I see patients for. We also deal with incontinence. That's for men and women. There's lots of different causes of that. We also take care of kidney stones when patients have those, and vaginal prolapse, and actually fertility issues for any male patient. So what kind of surgeries do we do that use the robot? So the robot is a tool. Your surgery is still performed by your surgeon. It just helps us do things better. The robotic surgery systems like Da Vinci, they've actually came out in the late 90s, and at this point we're actually on our fifth iteration of those robots. But these surgeries might be cancer surgeries to primarily remove an organ that has cancerous tissue in it. That could be your adrenal gland. Those are the things that sit atop the kidneys that produce adrenaline. It could be your prostates, bladder, kidney, ureter, which is again those drainage tubes, or a lot of times we're removing lymph nodes in those organs or around those organs to help with the cancer outcomes. We also treat several areas which are non-cancerous options that we use this for. Those are usually removing organs or a portion of organ that is not cancer but is not working or has been badly damaged and is causing issues. This is also might be in the case where you have blockage of something, and that's why I say we're plumbers. We kind of put things back together. Or occasionally you have connection between two things. That might be, if you had your real bad diverticulitis and the bladder connected to the colon, you might work to separate those two things. So we have a broad range of surgeries we do that the robot is helpful for us to do. So how does robotic surgery work? There's a few components of it. This is kind of a artificial drawing of what happens during Da Vinci robotic surgery. So the patient is here on the table and they're positioned in the proper position. The next thing that we do is we create really small openings in the patient's abdomen to allow these other tools to pass in there. And the abdomen's blown full of gas, and this is called laparoscopic surgery. So robotic surgery is laparoscopic surgery. It's just done with the aid of the robot. So then we put this machine in here, which has these robotic arms, and these are attached to these little openings in the abdomen that give us a way to put in instruments or put in cameras. So then these instruments are then attached to the Da Vinci robot, and that allows us to do the surgery. The surgeon is sitting in another portion of the room, as you can see on the right here, at a console. Console, you put your head inside and it gives you vision. So here's, kind of a cartoon drawing of what the surgeon actually sees during the operation. So after the whole robot's set up, they move to the other part of the room. There's still an assistant right next to the patient all the time who's helping with the operation, make sure everything's done in a safe manner. These instruments on there are then controlled. This is an example of one, this real small grasper here. They're controlled through little arms on the console. So when you're sitting there, you're moving your hands around, and that movement is mimicked inside the patient's abdomen. And so these arms of the robot control these instruments, and they are moved inside the abdomen. And meanwhile, the surgeon is doing this with a three-dimensional camera. So it tries to mirror very similar to what if we had a big open incision and had our hands inside there and we're looking at. So you're able to control this from this remote site in the room. So again, this is kind of what we're looking at, and you say, well, how does this help? Why do we need to do all this stuff? The robotics, specifically Da Vinci, and for a robotic platform like this, it does give us some advantages. We've had a big evolution of surgery. If you take, for instance, removing an organ inside the body, obviously we didn't start out with robots. What happened is we went from making these large open incisions to do things which are very difficult to recover from. They're very painful for patients. So then came along what's called laparoscopy, which is doing surgery through these small incisions in the belly. A lot of people have called this keyhole surgery. Well, what happened is that you can kind of think of it as you're kind of putting some instruments in the abdomen, but they don't have the flexibility and movement. So some of our more difficult operations that were done in real small spaces, like removing a prostate, they were very difficult to do even in that way. So the robot has given us this extra help. And what it's really done for urology over the past, 25 years is it's enabled surgeries that were very difficult to do with laparoscopy, even though laparoscopy had the benefit of shorter hospital stay, less pain for patients. And now we can do all of those through these real small incisions. The other benefits that the robot has, when we're looking inside that console, we're actually magnified 10 times. So if you were doing open surgeon, you're looking at it with your naked eye, you can't see the fine details that you can see with these cameras. And these cameras have gone through several iterations, and they're very good cameras with high definition. Um, as I mentioned, it's three-dimensional camera. So the camera we put in has two eyes to it, and that allows the feedback into the console to be three-dimensional vision. So that gives us that advantage to kind of let our brain believe we're in a 3D space. The other thing that happens is everybody's hands have very small amount of tremor. I don't have any tremor in my hands when I do surgery, but if you looked under a microscope, 100 times or 400 times magnified, you would see a little bit of motion in everybody's hand. So since I'm moving these little instruments, the robot takes out this micro tremor that's in there. The other thing that's helpful is when you're doing laparoscopy, you can only move in certain directions. When you have this, you can move your full wrist manipulation with the instruments. And that's really part of what has enabled us to perform these more complex surgeries through these really small incisions. The other things which we have seen a lot is compared to open surgery, these are all much less blood loss. Most of our surgeries, we don't lose very much blood at all. This has also enabled us with the combination of everything we're discussing, wrist manipulation, magnification or vision, 3D vision. We have much better dissection of tissues and organs. So all our surgeries, in my opinion, are much better than they were, before we had robotic surgery come along. So what surgeries are we doing at Valley View Hospital in urology? The first one on here, prostatectomy, which is removal of the prostate. That is definitely our most common operation that we are performing for patients at Valley View Hospital. This is done for prostate cancer, and this involves removal of the entire prostate. So removal of a portion of the prostate would commonly be performed for enlarged prostate, which is a separate disease process. Statistically, for Americans, about 1 in 5 men will be diagnosed with prostate cancer, and not all of them are going to get surgery. There are other treatments for prostate cancer, but we do offer this for our patients here. Just generally speaking, these I have personally performed several hundred prostatectomies. My other partner, Dr. Williams, also performs this operation. He's been in practice longer than I have, so he's performed even more of them. But we do a very good job with this operation, and it's something we've been doing for the past couple of years at Valley View. And then Dr. Williams and myself have been doing this at other institutions prior to that. So other operations we do, we remove the entire kidney or a portion of the kidney. That would be called a nephrectomy. That means that you're just removing the kidney or a portion of the kidney. These are most commonly cancer operations. So we try to do the best we can to preserve kidneys and only remove a portion of it to keep the rest of the kidney healthy. Sometimes somebody can have a kidney that doesn't work at all and it doesn't have a tumor, but it's causing problems like it's infected all the time, or it's has, extremely large kidney stones and is not working. So sometimes we remove kidneys not for cancer, but for other reasons. These other operations that are not bolded, these are less common operations, but all ones that we're very experienced in doing. Certain cancers arising from the drainage tube of the kidney or the ureter, you have to take that entire length of that out. That's called a nephroureterectomy. We also do some reconstructive surgeries where the kidney doesn't drain well. That's called a pyeloplasty. And then also any other issues of the bladder or where the ureter is not draining properly. We do those also to kind of reconstruct or reshape things to get things to drain properly, to be able to spare your organs, so you don't have to, eventually have a kidney removed, and so that works out well for a lot of those patients. Here, I'm going to show you an example of a few surgeries that we are performing here. So what our most common operation is robotic prostatectomy, what I mentioned. This is a prostate cancer operation. What you do in this operation is you remove the prostate and then reconnect everything. So this is kind of an anatomy diagram. The purple parts on that left picture, that would be your prostate. So you're essentially detaching it from the bladder and from the urethra, and then you're reconnecting those. That is probably our most common operation that's been performed. Whenever somebody comes into those operations, there's always a couple of side effects you can get from that. One would be urine leakage after operation. The second one would be erection issues. Both Dr. Williams and myself perform operations through what is called nerve sparing. This helps preserve these kind of things and helps with erection outcomes. I've been pleasantly surprised with my patients since I've moved to Colorado the past 2 years. Everybody has done really well with this operation. The ones that do have the urine leakage, it recovers really quickly. So this, again, is probably our most common operation, mostly because of prostate cancer being more common than some other things, okay? So we definitely offer that here at Valley View. This is an example of what's called pyeloplasty. So this is an example of a kink in the ureter where this kidney cannot drain. So you can see on the left side of your screen, there are two CT scans which show the kidney is just very, very full. That's kind of that darker gray in the middle, that's all urine. And then the right side is an X-ray showing just where this is getting very, very full and it's not draining. So that's an operation we go in there and we kind of reshape the drainage system. And this is actually one we did a while ago, and I just saw this patient back after 1 year after her surgery, and she's doing great. So instead of having a blocking kidney that is painful and is damaging this kidney long term, now her kidney is draining properly. This is an example of a kidney tumor. Okay, so this is a cancerous growth. If you look on your screen, there's both kidneys there, and the red outline shows the kidney tumor in that left kidney of that patient. So this is a scenario where, because of the size of the tumor, we're removing the entire kidney. We do these operations also where we're removing a portion of the kidney and not the whole size. Usually for cancer outcomes, if it's larger like this, we're typically removing the entire kidney. Smaller tumors, we can remove just part of the kidney. But this is another example of somebody over a year ago removed their left kidney. They're cancer-free at this point. They've not had any evidence of recurrence. These kind of operations, again, these are usually one day in the hospital. We do it through very small incisions. This is usually not a big prolonged recovery for patients. Most people are back to most of their normal activity within 1 to 2 weeks. And then they do have some lifting restrictions, which we keep for approximately 4 to 6 weeks, depending on the patient. But just so like with the prostatectomy, most of our patients are discharged home the very next day. So if you were a patient in our community and you had prostate cancer, a kidney cancer, one of these blockages or things, why should you have surgery at Valley View Hospital? So we have our robotics program up and running. This is our team. So there's myself on the left, and this is my other partner, Dr. Williams. Ashley Gilly from our office also assists all these cases. We have several staff, scrub techs and nursing staff that are very experienced with this, with the procedures that we performed here. So we do a very good job, in my opinion. This is this is not the only place I've ever worked, but I'm very happy to have such a good robotics team and staff at our hospital. The other thing I will just say about our hospital is it is an excellent place to get your medical care. This is a picture of the outside of our hospital. This is the nicest place I've ever seen or ever worked. All our staff are great. We don't really keep any slouches around as far as staff goes. So I think if you're somebody in the community and you end up with unfortunately, if you end up with one of these diagnoses and you want to know where's a good place to potentially have robotic surgery, for your and you're looking for a urologist, I think that our hospital and our staff is an excellent place to have this. So I'm going to go ahead and end the presentation there, and we will open up for any questions anybody has. Give us just 1 second.
Okay, so the first question is, if an MRI finds an area of concern for, say, cancer in the prostate, can urologists with the robot remove mainly that area of concern rather than the whole prostate?
Yeah, so that's kind of a complex question, and I'll try to break it down as best I can. So let me see if I can. Oh, let me do this again. So when you have a spot in your prostate that is suspicious for cancer, we give those a scale. It goes 1 to 5. They're called PIRADS classification. Depending on the likelihood of cancer, they're going to get a different score. So the first step would be anybody who has an abnormal spot in your MRI, you're going to want to have that biopsy to see if it is cancer or not. The MRI is not 100% accurate. It just tells us where our highly suspicious areas. The other set of procedures you would do if you were sparing the prostate or a portion of that, that would be called an ablation. So an ablation is a good option for if you have one solitary spot on the prostate that is clearly imaged and we know exactly where it is and we can burn or freeze that spot. For Valley View Hospital, we do offer high intensity focused ultrasound as an option for the right person to that, and that would spare a portion of the prostate. The difficulty is that the MRI a lot of times doesn't tell the whole story, meaning that there might be other areas of cancer in your prostate that we're potentially leaving in there, or there might be other things that we find out later that the cancer has grown through the edge of the prostate. Maybe it's gone into some lymph nodes. And so it's better just to have all the information and then talk to your urologist about whether you would be a candidate for an ablation or if the best option for cancer cure is to have something like robotic surgery or radiation might be another option.
With only a second part of that question is, if that can be done, would that reduce problems caused by a full prostatectomy?
Yes, if you underwent what's called an ablation, so you're burning or freezing a portion of the prostate, that has a lower risk of side effects. The specific side effects are incontinence, which happens after robotic prostatectomy, so it is much less likely to happen. The second thing is erection issues. They are still can happen with an ablation, they are just less likely. Now, not every tumor is a candidate for it, or if that tumor is in a location where the nerves and blood vessels that help with erections are right next to it, you might not get any benefit from an erection standpoint doing an ablation.
How is the robotic instrument sterilized to reduce infection?
Yeah, there's a standard sterilization process. So the instruments have a limited number of uses on them. They have 10 uses and they're thrown away after that point. That's more a recommendation from the company. But they use what's called an autoclave. Autoclave is like a really hot oven to cycle the things through there. And then there are other sterile processes when they're wrapping everything, and those are double checked before the instruments are opened and placed on the surgical field before the patient's even in the room.
Is a robotic surgery faster to recover from?
If you were comparing robotic surgery to open surgery, where we're making a large incision, it most definitely is faster to recover from. You have much smaller incisions and your pain is much better controlled. A large incision makes it high pain medicine requirements, longer to get up and walking and be active. So if you were to take an open prostate surgery compared to a robotic one, or open kidney surgery compared to a robotic one, The robotic one, I'm going to tell you, you're going home day one or day two. That's probably 95, maybe up to, 98% of people. If I did open kidney surgery on you, I will tell you up front that you're going to have 3 to 5 day hospital stay. And then that hernia risk is much higher. So just the people that are more than a week out still having pain at their incisions is more common. A lot of people are in the 1 to 2 week range to where they're essentially pain-free or they're not requiring a strong pain medicine with robotic surgery.
What are the latest recommendations for prostate cancer screening? Will my PCP let me know when it's time?
It depends on which PCP you talk to. So there are a set of guidelines out there. What our guidelines say to kind of try to make it easier is everybody at age 55 should be having a PSA at least once a year or every other year until they get old enough where it's not going to have a big impact. For the patients younger than 55, if you have a family history, so any first or second degree relative, so it can be, a father, a sibling, or if you have an uncle that has prostate cancer, you should get screened sooner. So that would start at age 40. But what I generally tell people, and this is what our guideline recommendation is, it is a good idea to get a PSA, which is a blood test, at least in your late 40s. What that does for you is just gives you a baseline, and it definitely lets you not be a statistic. I've had patients come in and they're 45 years old and have a bad prostate cancer. Those are not patients we want to wait till they're 55 to find out about it. So just having a baseline PSA, it doesn't mean after age 45 you have to get it checked every year, but at least you'll have a baseline and if yours is borderline or close to being elevated, then you can keep an eye on it and then get the appropriate evaluation once that is there. You can always discuss with your primary care doctor your concern and they will help you out. I don't think anybody's going to not screen you for prostate cancer if you ask them to. Okay. Okay, that's going to end our question and answer portion. Our team would love to hear your feedback on today's presentation. If you have time to fill out a quick survey, it will appear right after the webinar is ended. You will receive an email with the recorded webinar in the next 24 hours. And thank you for your time today. And please stay tuned for future Urology Valley View University. Have a good afternoon.